And this is our fourth webinar in Child Safety Week. So today we'll be exploring vulnerabilities in pregnancy and pre-birth procedures. So my name's Kirsty King and I'm the Practice Development Lead for the Medway Safeguarding Children's Partnership. And we will later be joined by Amanda Matter, and I'm sure she'll introduce herself again later, but she's one of the service managers in the Safeguarding and Quality Assurance team, Children's Services Medway Council. And then I'll pass you over to Becky, who is also our first presenter. So Becky, who'd like to introduce yourself?
Yeah, so my name's Becky Mulvaney. I am the Deputy Named Midwife for Safeguarding at Medway Hospital. And I'm going to be talking to you about our vulnerable pathway and pre-birth proceedings that we do here at Medway. Next slide, please, Kirsty. Thank you. So what we're going to go through today is just our whole process from booking up until discharge of our ladies that come under the vulnerable pathway. So we generally book women between 8 to 10 weeks of pregnancy. That's our guided time frame that we like to go by. Sometimes women book later, some of them book earlier, then we'll just get them to book between the adequate timing. This includes comprehensive history taken of all of our women, safe inquiry to ensure that there are no concerns with domestic violence or any other safeguarding concerns that we need to be aware about. From these safe inquiries and history taking, we then decide whether any referrals are needed to be made, which I'll discuss later on in the presentation. We also send notifications of pregnancy to GPs and health visitors, which the GPs will send back to us if there are any concerns with previous social care involvement as well. So if women aren't disclosing at booking, then that's another method of information sharing that we can gain that from. Thank you, Kirsty. Next slide. So so our response to any concerns with safeguarding, we've got many different methods and multidisciplinary teams that we can access. So our first one would be Midwifery Safeguarding Hub. So that is a MDT meeting that we hold each month, one for Medway and one for Swale. This includes health visiting, domestic abuse services, social care, maternity and health visiting. So our community midwives will email us through any concerns they have, and then we will escalate this at the meeting and come together with an outcome. I'll touch a bit more on this later in the presentation. We have constant sort of communication with all of our midwives. If they've got any concerns at any point in any pregnancies, they liaise with myself and Hannah, who's the lead for safeguarding of the trust in maternity. We also speak daily with social care, so they might get sick of us at some point, but we've got quite a good relationship with them for, again, information sharing and plan making for later on in the pregnancy and after birth. We also utilise meetings with the Windmill Clinic. So these are for our women who are actively using substance misuse, so any drugs or alcohol. That again is a multidisciplinary agency that include mental health, safeguarding and forward trust to ensure that our women on that pathway are either under their services with forward trust if they're on the methadone program and things like that, just so we can ensure that those women are followed through as such, so we can keep an eye on them and make sure that they're on the road to recovery, or if they are still actively using, then we are aware of that. So all of these we gain loads of information that we keep on file and that we share between all professionals. If there are any concerns, if people have social care involvement, if they're under the Windmill Clinic, they will be under our Team Connect team, who are our safeguarding midwifery team who deal with them on women on the front line as such. So they will see them in the antenatal and postnatal period and deal with all of their meetings throughout their pregnancy, and just make sure that we've got a plan in place when they come to us to birth. Next slide, please, Kirsty. Thank you. So our maternity support forms, this is what the main thing we use for our information sharing, so that we ideally don't miss any important information. So the community midwives will commence these at 16 weeks of pregnancy or at booking. So if they do have any concerns that they have raised to us, or if we have heard them at our maternity safeguarding hub, they will put all of that information down on the forms for us. Basically, that then gets sent to us. That's just for us so that we can identify any vulnerabilities. We can make plans for support for the families. The minimum amount of updates that we require on these forms are at 28 weeks and 36 weeks of pregnancy, and then including the first day postnatal visit and then the discharge as a minimum. If there are any other concerns or any other information that comes to light throughout the pregnancy, then these also get updated throughout, including when we hold meetings such as CP or CHIN meetings. This form is uploaded to our patient electronic record, so any professional that comes across them in maternity that looks after them are aware of all the concerns of the plan that's made, so nothing is missed, and we contact social care when they attend in labour and for delivery. And the girls also send us a copy as well. Sorry. And to the health assistant and the GP. Thanks, Kirsty. So our pathway that we would follow. So from booking, if we receive a referral to our maternity hub, we then have the hub meeting, get an outcome, identifying the risk and making a plan. That is where we would decide if women need referrals to a direct social care referral, if we refer to early help, if they just need to remain with their community midwife, but just that little bit more time given in certain appointments and things like that, or signposting to other professionals such as domestic abuse services, forward trust, anything like that. And also then that's when we would consider transferring to our Team Connect team, so our safeguarding team too, because they can offer a little bit more continuity of care because their caseloads are smaller, although their workload is huge. So we have quite a strict criteria of what we transfer to them, which is here for the thresholds. So yeah, there's an extensive list, but I'll just skim over them really. So current or previous social care involvement, if their children were on any previous plans, so child protection or child in need plans, if there is current domestic abuse in the relationship that they are in, or if there's historic that still impacts with their family at the moment. So if they're still in contact with the previous perpetrator because they still have contact with children, then we would like them to be under Team Connect. Any asylum seekers or refugees or people that have no access to public funds, teenage pregnancy, so if anyone under the age of 18 by delivery, then they would be under the team as well. Current or increased risk of exploitation, complex mental health, significant concerns of neglect, care leavers under the age or up to the age of 25 are under our team as well. Any concerns of homelessness, learning disabilities, surrogacy, concealed pregnancy, adoption, and postnatal transfer of care from another trust where babies on a child in need plan or child protection plan, our Team Connect girls will see them in the community then as well. Thanks, Kirsty. So as well as supporting staff, Hannah, the lead for safeguarding and maternity, also holds regular supervision. So we have lots of different meetings with these. So our Team Connect team, we have supervision. It's every 3 months to talk through their whole caseload and go through all the cases, make sure that everyone's happy and sort of singing from the same hymn sheet and that we're not missing anything. With our community teams, we have monthly drop-in sessions, so that's done via Teams. So if the girls have any concerns with any of their ladies on their caseload, they can come on Teams, have a chat with us, and we can just make sure that they've got enough support and guidance with looking after these women. If they're struggling, we can help them, or if they feel like they need transfer to Team Connect, then that's when we can discuss these concerns as well. Hospital supervision is something that we are trying to implement. It is finding it a bit difficult at the moment because I'm sure, as everyone's aware, hospitals are very busy. So holding sort of regular meetings for hospital staff, sometimes we probably wouldn't get as good attendance as we need to. So we're working closely with the adult and children's safeguarding team at Medway Hospital to see how they implement this into their practice so that we can try and provide that support for our hospital staff as well. Thanks, Kirsty. So prior to birth, so Medway and Kent pre-birth procedures, it's important to understand the circumstances of when referral is required to local authority directly. So for just some examples of what we would be looking for to make a direct social care referral. So parents whose children are currently open to the local authority, children's social care services, or closed within the previous 3 months may require additional support depending on the impact a new child may have to the parents' ability to provide adequate care for all children within the family. Any female child to be born to a parent who has been subject to female genital mutilation, so FGM, must be considered to be at risk, as much other female children in the extended family. So when a community midwife does a booking appointment, one of our screening questions is if mum has undergone FGM. If they answer yes, then that will be a straight referral to our maternity hub. We also hold a risk assessment with those mothers as well to get their views on FGM, whether they agree with the practice, disagree, obviously make them aware of the legalities around it, that it's illegal in this country, and that we don't accept that being done here. So we have regular risk assessments throughout the pregnancy and postnatal period for those mums. If we have any concerns with parents that they believe that this practice is okay and that they would be happy to undertake this once their child is born. If they have a female infant, then, well, regardless whether it's female or male, because we won't know at the time of booking, we will refer them to social care, and then escalate to health visiting to keep a track on those families, just to see their ingoes and outgoings of the country, to see if they're at risk of FGM. Also, direct social care referral is required if a child under the age of 13 is pregnant. Concerns that if a child is at risk of significant harm, including the parents previously suspected of fabricating or inducing illness in a child, if there's a risk of sexual exploitation, and also other parental risk factors such as domestic abuse, mental health, illness, and substance misuse. So our escalation process. So our community midwives would then escalate to their team manager. They would then escalate to the designated safeguarding team, so with us in maternity. And then if we had any further concerns, then we would escalate further and further to gain more insight. Also, an alert form would be completed as well. So if we are concerned of safeguarding risks and we think that a family are at risk of fleeing to avoid social care involvement, then we can send out local hospital alerts, but also national alerts as well. So social care deal with the national ones, we deal with the local ones because we're in contact with local trusts also. Thank you, Kirsty. So this slide is about our social care midwifery pathway. So if a referral is made to social care and closed, then we also request a copy of the assessment as well for our files, just to make sure that we've got those details, and we also document this on our maternity support forms. Learning from local children's safeguarding practice review, an assessment was completed and a family offered early help, however the family declined. So yeah, early help is a voluntary program, so parents can decline input from those, as well as DA services as well. So if the assessment was seen by a midwife, additional support could have been explored. What actions were identified for early help, as midwifery may have been able to support these in the absence of an allocated worker? So a lot of this is down to professional curiosity, really, and divulging and seeing how much we can support as a service, and identifying what goes outside of our remit, so that we can refer to either early help or signpost them to early help, because you can actually self-refer to them as well also, or for a direct social care referral. Thanks, Kirsty. So when our ladies move out of area within the pregnancy or in the postnatal period, these are the steps that we take. So it's always important to ensure that the midwife is aware of the area that the family is going to, so obtaining the address. We then contact the local trust and provide them with any safeguarding concerns that we have. Same as if we have anyone transferring from another trust, we would always email the safeguarding team there to see if there had been any concerns that haven't been disclosed to us that they're booking with us. ensure that all professionals working with the family are aware of the concerns. So if we have any other maternity support forms from other trusts, they will be uploaded to the Ladies Euroking account as well, so that for the information sharing. And it's important to understand that the midwife transferring the care holds the responsibility of the service user's care until all processes have been followed. So it's not a case of the lady saying, oh, I'm moving out of area now, see you later, and then we don't do anything more about it. We need to confirm that a transfer of care has been made, that she's booked with another hospital, and that any concerns have been forwarded to them as well. Thanks, Kirsty. Also, for learning disabilities and neurodiversity, so we do have hospital passports that we have previously used. We've had more meetings recently with our MD team, including our LD nurses, that we need to sort of be better at utilising these, because we've seen a gap in the usage of them recently where they could have been utilised much better. So yeah, so if anyone comes off with learning disabilities and neurodiversity, then if we fill out this hospital passport, that is on their file. They can carry that around with them. So whenever they attend hospital, we can understand if they need any further support with their extra needs. We also work very closely with our learning disability team here in the office. So we always interact with them and we'll ask for any advice if we need to. And it's also to see if we need to make any reasonable adjustments for certain ladies. So if they attend the hospital and we feel like they need any adjustments at all, the earlier the better, that we get the hospital passport in place and speak to the right managerial team to make sure that these are in place before birth. Thanks, Kirsty. So what happens if vulnerabilities are identified later in the pregnancy? So sometimes they are not always disclosed at booking, or sometimes an event happens within the pregnancy that we're concerned about that is then escalated to us. So what we look at is we need to explore the vulnerability. So which referrals are required? Do they need a direct social care referral, or do they need early help input? Do they need domestic abuse support from the HIDVA or IDVA? How else can we facilitate supporting them as a midwifery team? So would they need to be transferred to Team Connect? So we do have a threshold for Team Connect, and that's under 31 weeks of pregnancy, just so that we can, because if they've been booked with a certain midwife for that length of time, sometimes it actually is better for them if they remain with their named midwife, because they've built up that good open relationship and have a bit more of that open, free-flowing conversation. So in that instance, we would then recommend allocating a little bit longer for appointment times within their clinic. If we can facilitate home visits, sort of every other visit, rather than coming to clinic if they're having trouble with transport and things like that, or funding to be able to get to clinics. So if ladies require a bit more input, however, they do not meet the sort of transfer time to transfer to Team Connect, then myself and Hannah will always support any staff member with attending child in need meetings or child protection meetings, and just with completing all of those forms and answering any questions that they've got and supporting them as much as we can. Next slide, Kirsty, thank you. And just a bit more on information sharing. Our whole job is around information sharing, really. So professional curiosity, we say this a lot. So we always advise our midwives just to, if someone says, oh, I've had social care involvement in the past, but it's nothing important now, we just need to dig that a little bit deeper, really, and find out if the children want a plan, and just, you still with the same partner, is it a different dad now? Just so that we can gain insight to see if there is any significant risk that we need to escalate. Also, the importance of information sharing around concerns with other professionals and concerns that they have, because when we have the meetings, we might not know extensive history at all, but then the health visitors come in and give us a load of information that is very helpful. So us holding those MDT meetings are very, very helpful for us. Also, unseen fathers and sharing of information. We're seeing a rise of that at the moment with hidden partners. So people aren't disclosing who father of baby is, which is completely right. It's completely up to them. But that also poses a risk to us because we think, okay, well, there must be a reason why you're not disclosing that. So that's when we would look to other agencies to gain any further information. So for instance, on our hub meetings, we can see if they're linked to any possible perpetrators of domestic violence previously, or if that's why they were under social care previously, or we can speak to our HIDVAs to see if they're known on their systems as well. Thanks, Kirsty. So when we eventually get to the point of delivery, if women are on, it's main child, if families are on a child protection plan, it's requested by the allocated social worker or us to hold the pre-birth planning meeting, just so that we are all aware of the plan going into birth. We need to complete this by 36 weeks to ensure that if sometimes babies don't come on time, so that if they do surprise us and come a little bit earlier, then this is completed and everyone knows the plan, whether social care needs to be made aware, because if they're going to issue court proceedings, etc., etc. So this information gets shared again on our maternity support forms. We have a separate pre-birth planning form that is then uploaded to their Euroking file. So then when they attend in labour or for induction, then it's that we have a very clear set plan of what needs to happen and who needs to be notified of their admission and delivery. Thanks, Kirsty. And following on from that, once baby is then born, we then have a pre-discharge meeting. So myself and Hannah will facilitate these up on the ward with social care. So this is following the birth of a child on a CP plan. It is agreed that we always hold a pre-discharge meeting after a pre-birth meeting with the parents. They're fully aware that they'll be bothered by us again, just to go over safety plans and discharge pathways. So it tends to be who attends, obviously the parents, if they want any further support from grandparents or siblings, anything like that, they are more than welcome into the meeting as well. A member of the safeguarding team, so myself or Hannah. If neither of us are around, then it will be facilitated by our team Connect midwives. Also the caring midwife who's looking after them on the ward, so that they can provide an update of how baby's doing and how mum's doing. And of course social care, the allocated social worker will be present, and any support person that if they need any extra support provided by social care, they're present as well to give their version of events and how their stay's been in hospital. Thanks, Kirsty. So our maternity safeguarding team, which is myself and Hannah and Team Connect. So Team Connect, like I said, they do all of the frontline work. So they support our women for up to 28 days in the postnatal period. We don't necessarily see them every single day for 28-day care, but we will see them regularly at home, but also do phone calls between, just to ensure their well-being and their safety. We liaise very closely with the neonatal team as well. So if any of our women's babies come preterm, or if they need any treatment for withdrawal symptoms from neonatal abstinence syndrome, then we have a very close relationship with them. So we keep in touch with them every day to see how our babies are doing, and that we can update social care with the changes in clinical problems. We also support the families on the wards as well. So I regularly every day I do a ward round and make sure that our ladies know who I am, just so when I turn up for the meetings they're not completely shocked as to who this lady is, and just build that bit more of a relationship with them, so they're a bit more open and honest with us before discharge. Next slide please, Kirsty. Thank you. So who to contact if you're unsure or need any advice or anything going forward. So Hannah Gadd, she is the interim named midwife for safeguarding. That is her email address and number. That is my email address and number below, and also our generic email. So if you can't get hold of either of us, which you should because we're here every day, or Team Connect Community Midwifery Team, that is their generic email and phone number. So that's me done, I believe.
Yeah, one of my questions, Becky, the pre-discharge planning meeting and things, can they be multi-agency as well if they're being supported by, the domestic abuse services or the drug and alcohol services, or is that something that they don't really come to?
It's definitely something that they can come to and can facilitate. Sometimes we have had health visitors that have been, if people have had many children and they've had the same health visitor for all the children, then they can definitely, I've known them for them to attend. If the women are working closely with our domestic abuse HIDVA in the hospital, then sometimes they will attend also as well if we need to discuss sort of safety planning. Of course, as long as the partner of who we have concerns about isn't present, just to keep her safe. But yeah, the more the merrier with the meeting. So if anyone feels like they should be a part of it, then we've got no issues at all. We do hold the meetings in a safe space, so it's not in a four-bedded bay on the ward. We do have a separate room. So the long short of it, yes, like as many
Thanks,
people as
Vicky.
can.
Uh,
Yeah.
Thanks, Becky. And just to say, HIDVAs are hospital
Oh,
HIDVAs,
sorry.
independent domestic violence advisors. Yeah, no, that's fine. Just in case anyone didn't know that.
Becky, just a quick question. If, as community midwives, if we do a referral to social care, whose responsibility is it to find out the outcome? Because we don't usually get emails back from social care if they're taking on the case or not. So I feel like we do a lot of chasing as to find out the next steps.
Yeah, so it is. So whoever has made the referral, it's their responsibility to follow that up. What I generally say to people is if you sort of wait 2 weeks, then you can always email, depending on which, if you need to email front door or triage or the information gathering email, I can send them to you. Those are the people that you just need to say, I've done this referral, can you please let me know if this lady if you're undertaking an assessment for this family or if you've closed, please. And you can always sort of just always CC us into those emails as well, so that if you don't get a reply, then we can chase as well.
Brilliant. And if they do open an assessment, does that mean transfer to Team Connect or only if they then decide to put baby on a plan?
So it depends on the concerns that were raised. So say for if there is sort of ongoing cannabis use, for example, I'm talking in the scheme of things of the severity of what we see to not so serious.
Yeah.
So if it's ongoing cannabis use and they've opened the case, they're doing an assessment, but they're open to working with forward trust and things like that, then I would say by the time you've then handed over to Team Connect and then gone through everything, then by the time that you've done that, they would probably might have closed the case. So I tend to say if we wait for an outcome, whereas if it's as such as the other children are on a CP plan for neglect, other children have been removed, then I would say definitely we would just transfer to Team Connected. There's no point in waiting at that point.
Perfect.
So
Thank you.
it's case by case really, which is a bit difficult, but you know where we are anyway. If you're not sure on anything,
Brilliant.
just ask us.
Thank you.
Thanks,
Thanks,
Abby.
Becky. And I'd really reiterate that actually, that's a really important question, that because we see recurring in case reviews where referrals have been made and perhaps the referrer from whatever setting isn't necessarily always aware of the outcome of the referral, or there has been an assessment and they haven't been included in that assessment. So, we need to make sure that if we're concerned enough to raise this with another service, what is the outcome of us doing so? And if we're not part of that multi-agency assessment, then there's obviously going to be missing information, and if that is then closed and we don't know it's been closed and we're under the impression, we need to know the status of those cases. So yeah, I would say always follow up. So great question, Abby. I've got one question in the chat as well. Sonia said, can you give a bit more information about the fabricated illness? Who do we contact? Sonia, is that in terms of if you identify a pregnant lady, or is it just in a general sort of fabricated illness? Because as Becky said, so in general, so obviously Becky said there that is one of the triggers for referral for consideration for a pre-birth assessment. We also now have in Kent and Medway the perplexing presentations and fabricated illness support document, and that just explains basically what perplexing presentations are and fabricated induced illness, because obviously a fabricated induced illness, FYI, is very hard to establish. We need to go through the process of exploring what these presentations mean, and then the underlying issues as well. So we will pop a link to that document in the chat for you as well, so you can take a look at that. But obviously, as Becky said, it's already recognised in our pre-birth procedure. Okay, any other questions for Becky before I move on? No, lovely. Becky, Becky's hanging. Oh no, Christine, go for it.
Hi, morning. It's not a question. I just wanted to say to the lady earlier who spoke about not getting responses from social care. So I'm an early help partnership officer. So my role is to go into different settings and support with early help. And also we do support in terms of if you're not getting a response, you can get in contact with us. We've got one in each area in Medway, and we can kind of have a look and see what's happened with that referral and get you in touch with the social worker or early help worker.
Brilliant.
Oh,
And
brilliant. Have you got the contact detail for who we contact for that?
Yes, I'll pop my email in the chat, and I'll try and
Amazing,
get the
thank
other
you.
ladies' ones and put it in as well.
Yeah, that would be great for our files as well. And then if we get any queries later, then you're happy for me to share your information.
Yeah,
with them.
absolutely.
Okay, perfect.
Yeah.
Thank you.
All right, you're welcome.
Lovely, thank you. I think Becky's staying on the line, so obviously if you think of anything, pop it in the chat, and we can always revisit questions again in a moment. So Becky did allude to some of our learning from case reviews. So we at the MSCP undertakes multi-agency reviews where there has been a child who has been significantly harmed or died and abuse or neglect is known or suspected. So we discussed the cases and we agree if it's met this threshold, we will undertake a local child safeguarding practice review, or LCSPR. And these are the ones that we publish. So these reviews are all available to read on the MSCP website. You can read the full overview report, or there's briefings, or for some of the cases, there's also video explainers as well. So in terms of these cases for the antenatal period, obviously once the children were born, there were, other issues, especially around neglect and ongoing domestic abuse as well. So trigger warning, these babies did sadly pass away. So the LCSPR Laura was commissioned after the death of a 20-day-old baby. Laura is not her real name, it's the name given her in the report. This was in 2023. Her cause of death is unascertained, and this isn't unusual where there are signs of unsafe sleeping that have been associated with the death and no other cause of death can be found. So there'll be no further investigation necessarily into that. That's how it is recorded. And Laura and her family, they'd been away with relatives and they'd come home. Their mum had been drinking quite heavily during the day. And that night, Laura, her two siblings, and her mum all slept in the same bed. The next morning, Laura was unresponsive and couldn't be revived. Laura and her family were actually supported by early help services in Medway at the time of her death. And the family had been known to children's services in the past. They'd been subject to court proceedings a few years prior. They'd been on child protection plans, child in need plans, and the last child in need plan had actually finished in the summer before mum booked the pregnancy in the autumn of 2022. There was a large feature of the family's experience in the previous 7 years of a number of house moves. They moved 14 times in those 7 years. Many moves between the local authorities, which we know poses problems in itself in terms of sharing information and knowing where families are at any time. And this obviously impacts on the delivery of services. It pauses the services that are trying to engage in the family. It interrupts the service delivery or the plans that we're putting in place for the families as well. So as I said, mother fell pregnant with Laura in the autumn of 22. She booked her pregnancy with the midwives. At the booking, mum did disclose that there had been previous social care. In 2023, so the main period of like the antenatal care for Laura, there was a number of missed or rearranged appointments. Mum was offered targeted support for the duration of her pregnancy due to the vulnerability and the history of the family. So appropriate referrals were made to the maternity safeguarding hub that Becky's been talking to us about this morning, and it was discussed there in January 23, and the decision was to provide the extra support, but not necessary to make a referral to social care at that time. So came under Team Connect. The did not attend checklist was completed because, as I said, Mum missed some appointments, and the maternity support form was all commenced at that time and, shared appropriately. Later on in that pregnancy, it was actually the school that made a referral in March, and the referral was really a focus on Mum asking for help with the behaviour of one of the other children, but her mother's pregnancy was noted in that referral as well. At the same sort of time, one of the areas that family had previously lived in had contacted the housing from the previous area, had contacted Medway Children's Services because of the condition of her property that she was living in. So they'd inspected it and found evidence of drug paraphernalia, a white powder, unknown substance. The property was extremely dirty. The family did not appear to be actually living there. So she was actually given a notice to quit that one. Later in the month, they contacted Children's Services again because they were concerned about the extent of the way mother was heard to be shouting at the children. So an assessment took place. However, the assessment did not address the concerns raised about possible drug and alcohol use or neglect of the children. So the procedure that we have sets out the criteria for a pre-birth assessment, which obviously Becky said some of the aspects there that would trigger a referral. And Mum met at least 3 of those that we quote on the list. So a child had previously been removed, albeit yes, it wasn't. It was some time previously. There was concerns about drug and alcohol use, and this was prior to pregnancy. But then there was reports, obviously, during Laura's pregnancy about drug paraphernalia, and obviously the missed antenatal appointments throughout the pregnancy. And we know missed antenatal appointments can have like detrimental effect on unborns in terms of us being able to monitor the health of mum, health of baby, the support that mum and unborn are able to get. So there was opportunity for a pre-birth assessment to take place, but it didn't. It wasn't considered, so the right people weren't involved in those conversations. And when that happens, if there are referrals made and it is about concerns around the pregnancy, that's not addressed, or we're not engaged in the multi-agency processes, there are those pathways of check-in. I think Christine just shared one of the ways that we can sort of double check or follow up on that. And also Becky did mention the escalation process earlier. So the MSCP does have an escalation process. So if you are making referrals to services, any service in Medway, and they are not accepting it, or you don't agree with the outcome, and you've had the sort of first stage of a professional discussion about that, there are then stages that you can use to escalate that up sort of line of management to have a review of those decisions, and you can copy the MSCP in at each stage of that, because we are monitoring escalations in Medway now as well. So that was Laura. We also then had the LCSPR Isabel. Again, she was known for Isabel for the purposes of the report. She died when she was 3 months old in 2022. And again, the cause of death was unascertained, but she was known to services, and she was subject to a child protection plan at the time of her death. And it's thought, but not confirmed, that Isabel's death was a tragic accident linked to the unplanned sleeping environment where drugs and alcohol were present. So mum and baby had been sharing a bed. There are obviously, as I said, further learning points after the birth not listed here around domestic abuse, house moves, but during the pregnancy for Isabel, a referral was made to the midwifery safeguarding hub, because at booking, mum did disclose historical drug and alcohol use, and it is stated as historical in the report, but really we like to say non-recent, or actually she just said that she'd stopped, and now she was pregnant, so she would be using in pregnancy. But for whatever reason, the referral to the hub only referenced previous drug use, and it wasn't accepted to be heard at the multi-agency hub, so, which then puts it sort of on the radar of the other services, and there was no mention of her alcohol use. So the GP was informed of the pregnancy, as all GPs are informed of all pregnancies, and the GP did have a record that there was concerns about excessive alcohol use back in 2020, and mother had been referred to support and did not engage. And there was no, obviously, follow-up for them to know that that was not now the case. And there was also concerns about anxiety and depression that they had, and they could have triggered a referral to Children's Services and consideration of a pre-birth assessment. Mum also missed appointments, but re-engaged, and it was a pattern of re-engaging just as professionals were starting to be concerned about it. So when we are analysing missed appointments, in any period, I mean, obviously we're talking about antenatal period today, but in any period of time, we need to be thinking about what the impact of those missed appointments will have on the child. You know, is there a pattern to those missed appointments? Is it missed to engage in one, so we stop asking questions? It's, yeah, we have to look at all of those missed appointments as a whole, not just, oh, it's okay, she's re-engaged now. So since these reviews have taken place, the terms of reference, the criterion and the governance of the maternity safeguarding hub has been reviewed, and I hope you've been reassured by a lot of the work that Becky's spoken about this morning. There's been a huge amount of work gone into the antenatal period to support vulnerable parents, and we've also reviewed the Kent and Medway pre-birth procedure in that time. It was always there, and actually what the reviews found is that we weren't always using the existing procedures. That the real importance of today, especially listening to everything that midwifery are able to offer, is the importance of the whole of the partnership, understanding what the support system should look like for vulnerable parents, so that it's not in place. We can question, any professional can then question, say, oh, why aren't they undertaking it? What's the rationale? Health visiting also offer an extended service for vulnerable parents. So if they're not under that service, what's the rationale for them not being under that? And it might be that, that it was 32 weeks that we identified it, so they're not under Team Connect, but they're going to stay under their community midwife because they know them the best, and it's it would be detrimental, like Becky said, to move them into different teams. Now, Becky did mention a couple of the circumstances when referrals or requests for support can be made to Children's Services, and I'd just really like to re-stress the importance of referrals where there is knowledge that there are parental risk factors. So ones Becky mentioned about domestic abuse, mental ill health, substance misuse, and our understanding of how they may impact on the unborn child's safety or development, in utero, not even just the parent ability to care for the baby once they get here. And the impact that those vulnerabilities will have on the ability of the parents to meet the needs of the child once born. Becky did mention the challenges we have of invisible men, and men in the home generally, but we should be, during this antenatal period, also be aware of the vulnerabilities of father, because they will have an impact on mum, on baby, on the ability and capacity to care, the availability of parenting, and may also obviously impact the other social circumstances that we often look at, including homelessness or unstable homes. The other sort of areas, and again, you can look at this in the Kent and Medway procedures, are other people being in the home that are potential risk to the child, and if we have concerns about the parent being able to protect the child from those people that are a risk at the home. If they are late booking, denial of pregnancy, they've avoided care, as I've said before, they're not complying with treatment, any concealed pregnancies, so concealed pregnancies and birth without medical attention need to come in. And whilst we say, please make these referrals as soon as possible, and certainly, as soon as the baby is booked or we know that there is a pregnancy, if there are vulnerabilities, refer it straight away in. There's no minimum maximum time. You can always refer these in, but the earlier that they get referred in, the more time we have during that pregnancy for there to be multi-agency working, for there to be assessments, for there to be reassessments of risk, and for multi-agency meetings to take place as well. Should have Amanda on the call. Are you with us, Amanda?
I am.
Hand over to you then.
Great, thank you. So, perfect segue, Kirsty. So Kirsty's talking about when to refer. This is looking at kind of getting the referral right to get the response that we're looking for. So when making a pre-birth referral, it's what information do we need to put that helps that risk assessment? And some of this will be obvious, but does always is worth repeating. So anything we know about the parental history, whether there's a history of domestic abuse or current domestic abuse, mental health issues, substance misuse, or historic safeguarding concerns. What do we know about the current risk indicators? So is there a concealment of pregnancy, non-engagement with antenatal care, homelessness, or any criminal activity? Also identifying any strengths or protective factors. What do we know about any supportive family members or the level of engagement that we have from parents or any sort of positive changes, particularly if there had been, a previous removal at birth or historical safeguarding concerns. What's different now? What's changed? What is anything improved? We also want to know what the parents' response has been to your support, the advice that you've given them. Are they taking that on board, or is it that they're continuing to persist with those concerning behaviors? And as Kirsty had mentioned and has been mentioned earlier, paternity does matter, and it's helpful to clearly document what is known about paternity, even if that we don't know anything about the paternity, but it's about asking that question, noting if it was discussed and what the parents' response has been to that. If they've refused to disclose any information, that is helpful too. It's important for understanding the parental responsibilities, risks, and in our planning. And why does this matter? So the high quality referrals support quicker and safer decisions. And you may be the person who holds the key information that nobody else does. And in understanding who has the parental responsibility, it helps us understand that potential risk or what support, mum will get from fathers, partners, and if in the case that there's a need for any legal planning after birth, this is key for safeguarding and having an understanding of the wider paternal network. I think that's, yep. Kirsty, next slide, please. Yeah. So although a child and family assessment is completed by the social worker, many of you have been asked for information, and it's what do we do with that information and why is that information important? So your input into that assessment is crucial. And if you haven't been asked, it's worth kind of wondering why and speaking to the social worker. Because it helps build a full multi-agency picture of need and risk, and it offers clarity around the engagement, strengths, and the concerns. So when you're asked to provide that information, it's helpful if you can provide that in a timely way, providing specific and factual information. But also, we're interested in your professional judgment, describing any observations you've seen, any disclosures or any patterns of behavior that you've observed, and highlight any safeguarding history or known risks or strengths. This supports an accurate threshold decision of child in need or child protection. And I know that sometimes there is, professional difference of opinion around where that threshold sits. And so this is why it's important to have all that information and for that to be shared as part of that assessment, because it informs the development of effective and tailored support plans. And any decision on the threshold is based on the evidence that's been provided. When you've provided information, whether you're the referrer or not, you should be updated on the outcome of that referral or assessment. And you will be invited to be part of formulating and implementing a plan for the family if that's the decision or the outcome of the referral or assessment. If you haven't heard the outcome of your referral or the outcome of an assessment that you've provided information for, please ask, follow that up, and because you should be told. And and I appreciate that, we're not always consistent with that. But if you've been given information, you should have the right to know what the outcome of that was, and to be part of formulating that child in need plan, and contributing to that safeguarding process.
And we've also had a comment from Christine, from the Early Help Partnership officer team, just to say that obviously if social care recommended it for being a partner-led plan, then the early partnership team can help with that. Their role is to support and help put together intervention plans, complete parenting meetings, support with signposting and referrals, and facilitate reviews as well.
Yeah, no, absolutely. They're a key part of our offer, and I think the amount of support and intervention they can offer to families is considerable. And yeah, it's a very valuable service, not to forget that one.
And also I would say that during the assessment process, even if partners have contributed, if there was new information, so like house moves, new partners, relationship breakdowns, they all need to be fed in as soon as possible to the assessing social worker, so that they can read risk assessment that might change the trajectory of the work that we're doing, especially when fathers have been hidden and then we get an inkling of perhaps who the father is. It's really important that we let the network know, because it's likely there's a reason they've been hidden, and we need to make that association, really quickly. What I didn't mention in the case reviews is one of the dads actually had other children that he was not allowed to see because of his offending behaviour, domestic abuse, etc. And that wasn't linked to mum and unborn, because they didn't disclose that at that time. It wasn't until later we identified who father was. So really important. Becky's got a question.
Hiya, just a quick one from me, because I'm quite relatively new to the role. So recently we've had a lady who there was concerns with domestic violence, then reported it was historic. So social care, and there were other concerns as well. Social care put that she needed to be under early help. She then declined, so didn't meet threshold for social care input. They referred to early help. She declined early help input and also domestic service input. So if it was social care's referral to go to early help, but then she declined, where do we stand in? Do we re-refer then to social care to say that she's now declining this? Is that of a concern for social care?
I think the question I would be asking is, what's the potential impact? So if we've said that she needed this service to achieve A, B, C, and D, if she's declined that, which she's very much entitled to do, it's completely with consent. What's the potential impact? And that's on the basis on which you'd make that referral. So without that intervention, what do you think, in your professional opinion, is likely to be the impact on unborn? And that's where you make your decision, your advice from your safeguarding lead about whether or not you want to re-refer. The other point to that is, if you're not happy with the decision made by children's social care, I know Kirsty's mentioned this, that early in the presentation we talked about the escalation process. So as much as I'd like to think, you know, children's social care decisions are done and final, they're not. You know, as new information comes in, we need to reevaluate that decision. And if, you know, and sometimes, you know, referrals are written, and if you're not happy with that decision, sometimes a face-to-face conversation can help, and you can have that chat with our front door or with the social work team. And if again that's not able to be resolved, there is an escalation process in place. And the escalation process isn't about creating professional conflict. It's about resolving those differences in professional judgment, and it provides a learning opportunity, which is why we trying to track those escalations now, because there's important learning from that. And I think we've seen in perhaps too many cases where you know there has been differences of opinion and it hasn't been escalated, and those cases do tend to have, some of them have inevitably come back, and you think, oh, there was perhaps an earlier opportunity for the intervention to start. So those, you know, your views and your judgment is important. It's about what is the social work team or looking for in terms of maybe what was missed, and perhaps that's a follow-up conversation. You know, why are you worried? Why do you not think that that was the right decision to say? Family Solutions, well, you know, she's not likely to engage with that. So if so, why is it important that she does? What do you think, as from your position, feel that that is important that she does? What's the likely impact in your view on unborn baby or baby once born? That making sense?
And also just to reassure the partnership, you know, there are safeguards in place where if cases are stepped down, there is management oversight of that, and there is the availability of re-escalating cases if they feel that it shouldn't sit with us. But we can only go off the original information. Obviously, I know I mentioned a couple of cases where the information was shared that then perhaps didn't translate into the assessment, but then if the multi-agency are part of that assessment, we can also challenge the assessment as well and make comment on that. So yeah, so it's all about working together. Brilliant. Any further comments or questions in the dying seconds? I've gone over 1 minute. Thank you so much for your engagement today. Thank you for our presenters. We do have an evaluation form. If you could scan the QR code and complete that short evaluation form, it does really help us out in terms of further learning and, you know, what else we can put on for the partnership so we can learn together. So thanks all. Please complete the evaluation form, and the recording will be available on YouTube.